Okay. Okay, folks, our final lecture is coming up. Here we go. Sorry for the delay, but as you know, it's a very hectic time here. Okay, well, here's Sigmund Freud once again, just so you can see him. Hello, Sigmund here. The first slide of this lecture somehow does not want to show. This is the lecture of anger, hostility, and aggression. And I start out by saying that man is an animal trying to be human, meaning we still possess the ability for violence in our genes, and that's probably related to the survival instinct and the sex drive. But I do want to say, when I say it's man trying to be human, how do you define humanity? I would define it, civilized man, as having empathy for other human beings. And mankind has advanced greatly over the last 500 or 1,000 years. You might recall I spoke about in a lecture a few months ago that a man named Steven Pinker from Harvard did a study on violent deaths in humanity, starting from 500 years ago. And I believe 500 years ago there were 65 violent deaths per 100,000 people. That number now is less than 1%. During World War I and World War II, I believe the number was about 45. So we can see the world is becoming less violent. Most of you, or some of you might say, how can that be true? Because the media feeds us violence, because violence gets you angry and you keep watching that TV program. And then that TV station can sell their advertising space for more money. So what's happening now is the media is distorting the reality of human violence and existence. Okay, enough said with that. The USA is one of the most violent industrialized countries. Part of our culture is conquering. Okay, we can also say is crime is the price we pay for freedom. We could get rid of crime. If you steal a candy bar, we chop your hand off and you will never do it again. America, the punishment must fit the crime. So we sometimes, not always, treat people with compassion to some degree. Again, if you want to get rid of crime, you make the punishment so harsh that people will never do that again. Although humans are the smartest animals on earth, most human interactions are based on emotions, not logic. And that's a very, very important concept here when we're dealing with any human beings, but particularly psychiatric people with psychiatric issues working in a psychiatric unit. We must always remember that these illnesses are not logical. We have to find a way to get people on board emotionally. Okay, very, very important. Hopefully this is going to work. Okay. Anger is a normal human emotion in response to a perceived threat to physical or mental well-being or frustration. When people are frustrated, they can get angry. Let me just make sure this is okay. It's looking good. Okay. Always in the eyes of the beholder, what may not anger others may anger you. Okay. So we may not agree with what is making the patient angry, but we don't say, don't worry about it, or you shouldn't be angry about that. That is their reality. One thing we can learn in this course is we start where the patient is at. We can't tell them what we would do and how we would feel in that situation. Okay. Anger must be viewed through developmental age and culture. For example, temper tantrums are normal for toddlers, 1 year old, 2 years old, things like that. Temper tantrum is not particularly healthy for someone, above 25, 20, whatever. Okay. We now know repressed anger can result in illness, high blood pressure, ulcers, anxiety, depression. So there's a direct connection between anger and being ill or anxiety, chronic anxiety. Anger is a sign of an unmet need. Our job is to figure out what that need is in the assessment part of the admission of admitting a patient. And if we can meet that need through an intervention, we should. If we cannot meet that need, we should explain to the patient why we can't. Once again, I've said my mantra. Through education and explanation, we tend to get cooperation. So it's very important that we explain to patients why we do certain things. when people have a rationale and a reason, they're more apt to be cooperative. Okay? I was told this by a policeman, and I think it's very important in this lecture. As emotionality goes up, rationality goes down. Hold on one second. I just want to lower the heat in my house. Hold on. Hands, did you put the heat on? Okay. Okay, I am back. So again, when somebody is getting emotional, their ability to think rationally goes down. Let's talk about Freud a little bit here. Freud talked about two innate drives, and really, when we think of a human drive, it's really an instinct. There are others, but there's two here that apply: the sex drive and the aggression drive. These drives are primitive, as all animals need them in order to survive. On the other hand, self discipline and compassion are more advanced and more difficult to tap into. The root of empathy here really is the opposite of aggression is empathy, is the root of it is derived from a mother's nurturing and love for her child. So that is where empathy comes from. Men, women have it more readily than men. Men can learn it. For most of us, it is easier to get angry than to listen, understand, and be compassionate. It takes more self discipline. Talk about the expression of anger here. The inappropriate expression of anger, aggression towards self and others, hurting yourself, cutting yourself, getting in fights. That's an inappropriate expression of anger. Catharsis, venting anger in aggressive but safe ways. For example, hitting trees with baseball bats. This is no longer recommended because of the concept of kindling. If you remember, kindling is once you do a behavior or once you have your first depressive episode, your first panic attack, your first psychotic episode, it is easier to get future episodes. Okay. So we don't really want catharsis. We don't want to vent aggression and anger by beating a baseball bat on a tree or something like that. There are more appropriate ways to do it. Appropriate expression of anger, physical but not aggressive or violent activities. For example, walking briskly, running, swimming, riding a bicycle, vigorous exercise. So again, we're exhausting the emotion of anger, but not in aggressive ways. We can use anger to motivate ourselves to rectify a perceived injustice. And if we think, I think that we spoke about this in other slides previously in other lectures, Martin Luther King did just that. He used anger to motivate himself and others to rectify a perceived injustice. Okay, but he didn't do it in aggressive ways. He did it, but how Gandhi did it, by passive resistance. And I'll allow you to look that up. Mothers against drunk driving, mad. Students against drunk driving, sad. Mothers and students of friends who were, killed in car accidents driving drunk, they're upset, they're angry. They could take that anger and go beat people up. But the more appropriate way is to channel that anger to, in this case, creating an organization that educates people about drunk driving. Let's talk about the stages of anger. Usually patients will have an escalation period before getting violent. Okay, so normally on a psychiatric unit, or for that matter, anywhere, people rev up over time. You see them pacing, getting agitated. Now, that may not be the case in dementia or psychosis, because remember, somebody with dementia or psychosis, they're having internal voices. Their psychosis is telling them things, and we don't know what their brain is telling them. So when someone is psychotic, we have to be quite careful. In fact, I may have told you the story. I brought my students to a hospital out east. Um, I was with students, and they were helping doing some vital signs. And the patient was sitting down. He got up and punched me right in my nose, and then sat back down. Okay, I've only been hurt 3 times in the 30 years I've been doing this, and when we think about that, that's really not so bad because anybody working in a nursing home could very possibly get hurt more than that. Okay. Okay. So the stage here the trigger or provocation stage, there's a triggering event or thought, again, especially in psychotic or demented patients. Usually, for non-psychotic patients, there's an event that triggers them. But once again, when somebody's psychotic or demented, there's something going on in their brain, what they're thinking, that we don't know. At this stage, the person is still in control. This is the best time to intervene. Because once someone goes beyond the trigger phase, I believe the next stage is escalation, they're seeing red. And when people are so angry, they don't listen to anybody. So the key here is when you see somebody escalating or you see somebody triggering, beginning to go into this, you want to intervene right away. What do? We offer alternatives to deal with aggression, exercise of large muscle groups, walking, talking. Again, I have found when someone's angry, if I give them 10, 15, or 20 minutes of undivided attention, really listening to them, validating their perception of things. Again, I might not agree with it, but it's their reality. And I validate that I'm hearing them. I have found that 95% of the time, those patients calm down, someone's heard them, their needs have been heard and validated, and they're calming down. Trigger phase continued. Talking with the patient. Again, validating patient's feelings. I see how that could piss you off. Something like that. Help patient clarify what is bothering them by talking or writing down thoughts or in a letter. They can write a letter to somebody, maybe their father, maybe somebody from childhood. It doesn't mean they have to mail the letter. When we write down our thoughts, they are more concrete on a piece of paper and we can look at them. And if you think about that, that is the basis of poetry and music. People write words and put them to songs. That's the emotion coming out of them. If we have tried this and nothing has worked and they're still agitated, then we want to offer a PRN sedative. And this would be a very, very good application of a benzodiazepine. Okay. Because again, this is not something we're doing every day where they can get addicted. It's used rarely, but very, very effective. We could also use antipsychotics because antipsychotics, the sedating effect of the antipsychotic is immediate. The antipsychotic effect might take up to a month or so to have full effect, if not more. But the sedating effect of an antipsychotic is immediate. In fact, we'll see in a few slides what antipsychotic is used in this situation. The escalation stage. Patient continues to escalate despite verbal intervention and other means of de-escalation. Now things are getting serious. Okay. We must prepare for a manpower call. And what that means is that this team is going to assemble and be prepared to put this person in seclusion. The nurse needs to be more firm here. We need to talk calmly but directly. For example, Mr. X, it is inappropriate to threaten patients or staff. I'm asking you to stop this behavior. In a firm but kind voice. I realize you're upset, Mr. So-and-so, but I'm asking you, please don't threaten the staff here. Why don't we walk down the hall and talk a little bit? That's when you give them that 15 or 20 minutes of undivided attention. We want to try to isolate the patient from other patients because when there's an audience, the patient is going to rev up. When he sees other patients looking around, other patients will tend to come out of their rooms. They hear yelling. This is not much different when there's an accident on the LIE and everybody slows down to look. It's called rubbernecking. Everybody slows down to look at what's going on at the accident scene. Continue to try to talk to the patient. Avoid being alone with the patient. Okay, we don't want to be alone, but we do want to get the crowds of other patients away. So what might happen is you, the nurse, might say, Mr. So-and-so, why don't we walk over here? And maybe the nurse's aides or the other nurses take the other patients that have come out of their rooms looking for this, what's going on. Why don't we go back to our rooms over here? The crisis stage, patient acting out aggressively. Now we call manpower. And when we call for manpower, what we really want, we don't want to get physical with the patient. What we want to do is have what's called a show of force. Usually, patient will go into seclusion on their own when they see the show of force. So when you call a manpower call, once you do that, the patient is going to go into seclusion. Now, I truly believe that we should be using seclusion before restraints, because if you remember the concept of the least restrictive means to manage behavior, certainly strapping a human being down is more invasive than asking somebody to go into seclusion. Once we've called the crisis team, the patient will go into seclusion because we've tried other options already. We've tried talking, we've tried redirecting, we've tried listening. Okay. So with a show of force, the goal here is to have the patient look at the show of force, 8, 10, 11, 12 people, they go into seclusion usually. Manpower team will comprise of police, primary care provider, that could be a physician or an NP or sometimes a physician's assistant. Other nurses, the nurse takes charge unless the primary care provider is present. If the physician is there, they will take charge. Usually, many times, if the physician is in the ER doing other things, again, you've initiated this as the nurse. You have a right to do this because the patient's escalating out of control. The nurse takes charge, and police take orders from person in charge. The nursing unit is the nurse's domain. Policemen on the unit or security guards on the unit, in some sense, for lack of a better term, are guests. They need to listen to us. It is our unit, and we are managing the situation. Sometimes, and a policeman, I just want to make clear, there are some hospitals that do not have a large security force. So when they a smaller hospital, they'll call in the local police department. The police cannot bring their guns on the unit. I worked in a hospital. There was a crisis. The local police came. The charge nurse said, "You cannot go on the unit with your gun in your holster. There's a place you can lock it downstairs." And the policeman said, "I will not do that." And the nurse said, "Then you can't come on the unit." You can only imagine if that gun got into the wrong hands on a lock unit, what could happen. So once again, the nurse takes charge here. Okay? I want to make clear there's another hospital I worked at. The policy was whoever had the best rapport with that patient should be approaching the patient. And sometimes that may very well be the LPNs and the nursing assistants because the RN does administrative work many times. The NAs are out on the floor, the LPNs are on the floor. So if you have a particularly good relationship with that client who's losing control, the charge nurse may ask you to say, "Why don't you go in that room and see if you can talk to this patient to calm him down?" Because when you have a therapeutic alliance with that patient, he's going to listen to you more readily than he'll listen to somebody else that he doesn't know. Okay. So with this manpower call, you need at least 4 members of the healthcare team, depending upon the size of the patient. Of course, the more the better. A smaller patient, you can get away with, again, how old, how much, maybe, if the person's 80 years old and 110 pounds, you might just need 2 team members, but usually a minimum of 4. We want to keep staff and other patients safe until the manpower arrives. As this patient's escalating, you don't want to go out there by yourself because you might get hurt. So that's time. You need to buy yourself time, get the other patients in their rooms. Nurses stay behind the nurses station until the whole team is there. What usually happens is the team comes up the fire entrance on the back of the unit because the patient's expecting this team to come through the front door of the unit. So the team many times will come up an alternative route onto the unit. We assemble the manpower team. We designate who will take arms, who will take legs, and who will protect the head of the patient. We do this, but we cannot harm the patient. It's only to control the patient from harming himself or others. Crisis stage continues. Have one person do the talking and lead the team. Again, usually this is the person that has the best rapport with the patient. Other team members stay back just a little bit and be ready to assist physically if needed. Team leader asks the patient to go into seclusion. If patient refuses, on cue, you might have a word. You assemble the team prior to going out to the patient, and you might tell other team members, when I say, why don't we get a glass of water, that means we are going to approach this patient rigorously and bring him into seclusion. Patient refuses on cue, that cue being a word, have team quickly grab patient's arms and shoulders, walking patient backwards. What I have found is if each person grabs a shoulder and an arm and walks the patient backwards, they can't punch you because you have their arms, and they're off balance because you're walking them backwards. Okay? A fifth team member should protect the patient's head from hitting the ground. Again, we have to do this without harming the patient. Other members may have to grab the legs if necessary and carrying patient into seclusion. Again, it all depends on how big the patient is and how angry that patient is if they're fighting back. We put patient on one-to-one once they're in seclusion or 15-minute checks. What that means is when they're in the seclusion room, a nurse's aide, or an LPN will be sitting right outside the door and observing that client, okay? At minimum, they need to be on Q 15-minute checks. The point here is when they're in seclusion, we do not abandon them. We keep our eye on them. We need to meet their needs also. They have a right to have food, go to the bathroom, have fluids, things like that. And whether they're put on one-to-one or Q15 will really depend on hospital policy. Okay. Well, sometimes when you put somebody in restraint, they continue to be aggressive and they might even try to hurt themselves while they're in the seclusion room. Now is the time for restraints. And I think in the past, described restraints. And if anybody's ever looked at a horse saddle, there is the cinch that goes around the stomach of the horse, the chest of the horse, big, thick piece of leather. And that's what restraints look like. Okay. If putting patient in restraints, we'll need at least 6 people, as some must hold limbs while others apply the leather restraints. So first what goes on is this wrist bracelet type thing that is cushioned. It's made of leather with some cushioning on the inside. Through that is a loop where the cinch strap that I described is tied around here and tied to the bed frame. Must stay with patient if in restraints, as patient cannot protect themselves from others. Many times what happens is when people are put in restraints, they're brought in their own bedroom and tied to their bed. Now, this is not a seclusion room with a closed door. So if that patient was having a fight with another patient and you leave that patient alone, the other patient can come up and beat up this patient that can't defend themselves because they're strapped to the bed. So it's even more important that when someone is in restraints, we cannot leave them alone. Remember, we're here to protect the patient from themselves and others sometimes. Again, remember, seclude and restraint only used for protection of self and others, never, and you see it in bold, used as punishment. That's assault. When you use it for punishment, that's assaulting somebody or battery. Well, when someone is in seclusion or restraints, they over time they calm down. Most of the time, when someone is going into seclusion or restraints, remember, we've tried everything else that hasn't worked. We've offered them PRNs. Maybe they've refused it. When they're going into seclusion or restraints, they're 95% of the time, they're going to get a shot of Haldol, Ativan, and Benadryl. We'll see that in a slide or two. That kicks in about maybe 15 or 20 minutes to a half an hour. The patient begins to calm down. Okay. You usually need to be kept in restraints, seclusion and restraints for at least 20 minutes. I would say an hour is more realistic. As patient calms down, they begin to regain control. They begin to relax. We can explain to the patient what they need, and it could be a woman or a man. I know it's a he there. Men do have more aggression than women. We know that. What they need to, how they need to act to get, if explain to patient how he needs to act to get released. Ask patient directly, can he or she maintain control if released? We can actually ask them, Mr. So-and-so, if we release you, do you feel you can control yourself? Or do you feel that you're going to go back and get in a fight with the patient that that you had a problem with earlier? Okay. And they may say, no, I don't think I can do that right now. That's fine. Or they may say, yes, I can. The key with this, once again, is to do it in a way as best we can to retain somebody's dignity. The patient is removed from seclusion and restraints. You never do this by yourself. You don't need a full manpower call, but you want to probably have, depending upon the size of the patient, if the patient is quite big, you probably want to have at least 6 people to open up that seclusion room door or undo the restraints just to make sure that they're not going to lose control again. Because, again, we don't know. They could still be very angry and just kind of pawing with us, telling us, yes, they can control themselves, and then we let them out and they hurt us. We want enough team members to control the situation should it get out of control again. Discuss patient behavior with patient in a calm manner. Discuss other ways patient can handle frustration and anger. Maybe at this time or maybe even the next day. Mr. So-and-so, we don't want to have this happen again. What can we do for you that might help you calm down in the future should you get agitated again? We want to explore other ways of handling this with the patient. Okay. Some patients might say, let me just sit in my room by myself or let me listen to some relaxing music. If we can do that, fantastic. Okay. Discuss ways staff can help patient when patient is angry. Documentation. And I have to make this very clear. This is really important in mental health. Your note is your legal defense. In physical medicine, med-surg, we have lab values, x-rays, MRIs to say what's wrong with the patient. Okay. Usually there's a prescription. If you have this bacteria, you get this antibiotic. We don't have that luxury in mental health. Once again, we are operating somewhat blind in mental health because we have no lab work, no x-rays, nothing that can tell us someone's psychotic, someone's depressed, someone's angry. So therefore, you have to document very clearly, because if this ever goes to court, you put a young man in seclusion and parents are very upset and they say, we're taking you to court for assault and battery. Your note is going to be the explanation of everything you attempted prior to seclusion and restraints. Must document what led up to the aggression. Must document all interventions that were tried prior to seclusion and restraints. Must continually document Q15-minute checks, usually on a flow sheet, how patient is tolerating seclusion and restraints. Must document the patient's basic needs of hydration, nutrition, elimination are being met. So again, when they're in seclusion, we still have an obligation to meet their physical needs. Let's take a look here, some notes. Focus notes. And Stony Brook University, as far as I know, still uses what they call focus notes. And really, it's a DAR note, data action plan response. The focus here is behavior to data after phone call, patient pacing unit, threatening staff and others, verbal intervention, redirection and limit setting attempted with poor results, patient refused PO and IM medication, continues to threaten staff and other patients. Action plan. Crisis team called to place patient in seclusion for protection of self and others. Patient refused to enter seclusion room under own volition. Staff placed patient in seclusion. No injury sustained by patient. Patient began to bang head on wall. Patient placed, and in this case, the crisis team would have to come again. Patient to put the patient in restraints. Patient placed in restraints in own bed for protection of self. IM Haldol given per PRN order, will monitor per unit policy. And like I said a few minutes ago, usually the Haldol, which is a typical antipsychotic that's very sedating, is given along with Ativan and Benadryl, and I'll explain why in just a minute. The next part of this note is the response to this. Patient in restraints, resting in bed, offering no complaints. Okay, so this is a note that we've documented what we tried prior, what we did, and the patient's response. Okay, treatment of aggression. Usually treating underlying psych disorder will decrease aggression. So if someone is psychotic and having command hallucinations to hurt the nurses around him, If we treat that psychosis with antipsychotics, again, getting rid of the psychosis may take some time because it takes a couple of weeks, up to a month or 6 weeks, to get a full effect of an antipsychotic, as it takes time for antidepressants to work also. Okay. If we treat that underlying psych disorder, the chances of aggression decrease. Indoral, also known as propranolol, you may remember me talking about this, is a beta blocker, meaning it blocks the beta adrenergic receptor, the beta adrenaline receptor. When you block adrenaline, adrenaline makes you hyped up nervous. Best thing I can think of adrenaline is caffeine. If you had 40 cups of coffee, you would be very shaky, agitated, and irritable. Okay, it's overdose on caffeine. We can give the person propranolol Indoral that blocks their adrenaline and calms them down. Again, it's an old high blood pressure medicine. PRN treatment for acute aggression. Let me go back one slide. These treatments here are getting or not, they're used for chronic treatment every day. The person would take propranolol every day. The person would take an antipsychotic every day to get rid of the psychosis. In acute aggression, this is the person right now losing control, Haldol 5 milligrams and Ativan 1 milligram. IM, intramuscular. So Haldol we know is very sedating because it blocks dopamine. Ativan is sedating because it elevates GABA. Ativan will also help reduce the chances of EPS because if you remember, older antipsychotics, which Haldol is, can have extrapyramidal symptom side effects. So Ativan and benzodiazepine will help that. And sometimes we actually add Benadryl because Benadryl is an anticholinergic, which also will reduce the EPS side effects. And we also know that Benadryl is also sedating. There's a medicine also called droperidol, which is the Haldol derivative. It's highly sedating. From what I have heard, I didn't use it much, that it could have some cause some cardiac conduction abnormalities. So what I have seen in my career is Haldol 5, Ativan 1, sometimes 25 of Benadryl added in there also. Well, some stories. As you know, I like to talk about stories. There was a bipolar patient. There was another patient who, very sadly, was having command hallucinations, telling him to jump out the window. This was a hospital, a big hospital with many, many floors. This person, bipolar patient, heard the commotion, came running around the corner, and said to me, "I will fix the patient for you, Mike." And I forget his name. I'll call him George. I don't know. I'll handle this, George. Please let me handle it. Okay, Mike, but I'm here to help you. Thank God he stayed out of it. And I want to make clear that this bipolar patient, I had a therapeutic alliance with him. He was admitted to the hospital because he attempted to hurt his ex-girlfriend's new boyfriend in the nursing home where he was living. He was very sad. And I would go in his room every shift for 20 minutes and just sit with him. Or maybe I'd go in for 10 minutes, do some meds for 2 or 3 hours, come back and sit with him. He needed that. So what I did with him is I created a therapeutic alliance. If I didn't have a therapeutic alliance with him, he may not have listened to me when this patient was trying to push the window out of and jump out the window. Okay. Well, there was another patient in my career who was admitted. He had some dementia. He was, hitting his wife. His wife came to visit him. The head nurse said, "Mike, his wife's here to visit. Please just stay close to him. Make sure he doesn't hurt his wife while his wife's visiting." I was sitting to the patient's right. The wife was sitting to the patient's left. And I was just nonchalant, kind of watching TV, and he's conversing with his wife. And out of the blue, he backhands me in the nose. And that time, my nose did bleed. Hey, there was another situation here of a guy who knew karate. He was very buff, lifting weights. He was doing karate katas in the hallway, visually really aggressively in the hallway. And obviously that's inappropriate. I went up to him and said, I guess his name was I'll call him George again. George, I, you're really scaring the other patients here. Look at the World War II vets down the hall. Look at they're afraid to walk by you. He said to me, I'll kick everybody's ass here. Now, that could be seen as a challenge. Like I said in the beginning of this course, we don't have to win the ego battle. My response to him is, there is no doubt you will kick everybody's ass here. His response to me was, I'll kick your ass, Mike. And I said to him, there is no doubt you will kick my ass. The point here is, we don't have to win the ego battle. I continue to tell him, George, the World War II vets, these guys are, 80 years old. You're 25. They're afraid to walk by you. Look how afraid they are. Can you do me a favor, George? What do you want, Mike? Can you do your karate katas in your bedroom? All right, I'll do that. Fine. That's good enough for me. Do I like the idea of somebody doing karate katas in their room? Totally no. But at least we got him out of the hallway and this situation was not escalating. He was looking to be an alpha male. He was kind of looking for a fight. I validated him. You are the alpha male. You'll beat me up. There's no doubt about it. But before you do that, can you go in your bedroom and do the karate katas there? And he agreed. So again, I de-escalated a situation that could have very, very, very easily got out of control, and somebody would have gotten hurt. I think I told you about the patient who punched me at the hospital in front of the other students a little while ago. I think I had mentioned also there was a patient who was probably antisocial who he wanted benzos from me. He saw me alone in the front of the unit. He came up and said, I want my Valium right now. I just don't hand out benzos. Okay, before you're going to get a benzo, let's talk about what's bothering you. Because if we give patient benzos every time they ask, what do we tell them? We tell them, you can't solve your own problems. You need me forever, and you'll need this medicine forever. And a benzo, we know, could over time create a habit, a drug addiction. Okay, well, he didn't like that answer, and he tried to hurt me. Very sadly, I had to call a manpower call, and we had to put him in seclusion, basically to protect other staff members. I want to mention something else. There should be no weapons on a psychiatric unit. But one thing we can use to prevent being hit by a person, if the person has a cane or something, or even just their fist, is a mattress. We can take the mattress off the bed, hold it about chest level. One or two or three people hold this mattress and walk toward the patient. The patient can try to hit you, but he can't reach over the mattress. At some point, if the patient is up against the wall, now we can put the mattress down and take control of the situation. So a mattress can be used as a defensive tool to not get hurt, as a cushion. Nursing process. Assessment. We constantly observe for signs of anger and aggression, pacing, yelling, threatening, unusually quiet, isolating, angry look on patients' faces. You see, this is doing good. It's still doing good, I do believe. Okay. Um, we have to know the patient's baseline because patients might be in the hospital and their norm is to just pace. They might be a little loud and yelling at times. It doesn't mean they're agitated. So we must know their baseline. Let me just try to fix this a little bit more. There we go. Okay, I think that's a little better there. Okay. But generally, if someone's pacing, yelling, threatening, unusually quiet because they're normally more friendly, now they're seething quietly in their room, isolating, angry look, we want to attend to them. Okay. Firemen don't run out of burning buildings. They run into burning buildings. Nurses should not be running away from angry patients. Now, we don't want to get hurt, but an angry patient needs attention. When someone's angry and you ignore them, they may very well rev up. Remember, anger is an unmet need. The patient's frustrated. If we ignore them, they may very well escalate more. So when you see anger, you approach the patient. So-and-so, are you okay? You seem a bit upset. Why don't you come over here? We'll walk a little bit together. Come on, we'll talk a little bit. Again, I get it that angry patients, it's a little scary, but as psych nurses, we have to attend to them. They need our attention. I also want to talk about observe patients after a phone call or family visits. When families, the wives call, the husbands call on the phone, or that can be a very, very emotional time. Okay, we want if the family leaves or we notice the patient after the phone call is very upset, we want to attend to that. Okay? We're not listening for every word in their phone call. We're not eavesdropping, but we might be listening for a tone of the conversation. Is it an angry conversation? And if we see the patient escalating, Mr. So and so, what's going on the phone? Well, my wife is divorcing me. Okay, let's talk about that. And again, remember, anger usually results from an unmet need, the need for respect, the need to be heard, etc. If we can meet that need, we should. If we can't meet that need, we need to explain to the patient why we can't meet that need. Now, this patient who wanted his Valium, I would give him Valium if we spoke and talked and he still was upset after, 10 or 15 minutes of talking, he was still upset. I have no problem doing that. But to just give somebody a benzo, we're teaching him that he can't solve his own problems. And it might be a cop out of the nurse unwilling to engage with the patient. I ask you, if you're going to be psych nurses, we must be interested in our patients. That's our job. Some nursing diagnosis here. Certainly ineffective coping. Acting out aggression is not really effective coping. Certainly risk for injury, risk for other directed violence. And there could be many, many more here, but these are the big three. I don't know what happened there, but let's go through this. Again, we begin with least restrictive measures and only progress to more restrictive measures if least restrictive measures have failed. This is the order of interventions. Interventions for acute aggression in priority order. Verbal intervention, talk with the patient, try to address what's bothering them, or talk them down during the trigger phase. Limit setting, Mr. So-and-so, I'm asking you not to threaten staff. Please, that's inappropriate. We are here to help you. Offering a PRN medication, either PO by mouth or even IM. And then we go to seclusion and restraints. Once again, I don't know if you can see it, the very bottom, seclusion and restraints are never, ever, ever used as punishment. Interventions for avoiding aggression. Establish a therapeutic alliance. Again, in mental health, this is the key to all relationships with patients. We want them to realize we are not against them. We are on their side. The goal here is for them to have a better life, as all healthcare is, right? We monitor all patients for anxiety and frustration, which is usually the precursor of aggression. Keep an eye on patients who have had visitors or who just got off the phone. We can teach assertiveness training. And something I learned working in rehabs is assertiveness is saying what you mean without being mean. Aggression is just being mean, right? But assertiveness is saying what you mean without being mean. I thought it was a very wonderful description. Okay, what's going on? Conclusion. Do not take anger personally. Remain non-judgmental. Remain calm. Slow the situation down. In med surge, when there's a crisis, things go into overdrive. When someone talks about chest pain or having a heart attack, nurses grab the crash cart, everybody comes charging on the unit. In mental health, what we want to do when a patient is escalating is slow things down, calm things down, because remember, more agitation is going to upset this patient more. So we want to also buy ourselves time to assemble the team. So we want to remain calm, talk calmly. The patient might be yelling. We don't yell back. We talk calmly, assertively, but calmly. Okay. Be aware how you handle your own anger and the anger of others. Seclusion and restraints, again, I repeat this over and over, only used for protection of self and others. Okay. Okay, let's stop right now. I'm going to reboot for the next lecture. Let me just turn this off. Hold on. Okay, here we go.